thank you very much, everyone, for having us. So I will begin, and then I'll be sharing this with my colleague, Dr. Valerie Obare, at the evaluation section. So let's just look at the outline. So basically, we'll talk about the background, where we will demonstrate the rationale and the context for the work and the methodology that was used. And then we'll talk about the implementation results, which I will mention the sample case studies, and then Dr. Valerie will discuss the evaluation results. And then we'll also just share the lessons that we've learned from this. Next. So just to give us a background for what happened. So in the midst of ART scale up, test and start, which was a policy in Kenya, the Ministry of Health, in collaboration with the Global Fund, collected data initially for existing differentiated service delivery practices in select facilities based on WHO guidance. And the main reason why we're doing that was to identify the workarounds for health workers for delivery of quality services in the context of the heavy workload because of the rapid scale up. So interestingly, from those findings, we realized that the workarounds were quality improvement initiatives. And so this led to development of the DSD guideline and toolkit, just to support, to provide guidance around how to standardize quality service delivery as we rapidly scale up quality over, as we rapidly scale up ART. And so because of the findings we saw, those interest by the Ministry of Health to be able to roll out DSD in a quality improvement environment. And so we were able to collaborate with the Global Fund, with their support, to be able to see what's going on when you use that environment for quality improvement to scale up DSD. And so 7 counties were selected, and we went into specific health facilities in the 7 counties. And the collaborative stakeholders included both national and sub-national teams. So we had all, the whole slice, right from the national development partners to county to facility teams. Next. And so the main goal of this work was to produce evidence that using quality improvement approaches to roll out DSD was able or could lead to better patient health outcomes and program efficiency. More specifically, we're interested to showcase that you could actually use quality improvement to integrate at least one differentiated care approach along the cascade of HIV care, so right from testing all through to retention and suppression, and also measure the impact in terms of quality improvement indicators across the cascade, and determine the cost efficiency for DSD models and patient outcomes, and then also specifically be able to document the process of implementing and lessons learned for the purposes of replication of what was going on. So as part of the role of the stakeholders, like at the national level, was project design. They were able to design the project and coordinate its implementation. And one thing that the team was able to do was apply a QI concept where they used the driver diagram to develop a theory of change to exactly what would happen in the project cycle. So they were able to link the main outcome, which was mainly to ensure that we are suppressing clients, but using a quality improvement approach in DSD. And we were also able to link certain primary drivers, just looking into what are these drivers that would support the outcome, what are these secondary drivers that would support the outcome, and what are the likely change interventions to look out for, a boardroom discussion to think through that theory before implementation. Next. And so the work was selected in 7 counties, as I'd mentioned, and there was a select criteria for that. And most importantly is that we're contextually looking at what was going on in the country in the rapid, the test and start. So, high prevalence, high incidence, and also where the volume of work is. So county hospitals where there was high workload. Next. Just to mention, sorry, Sarah, that again, it was interesting that the select counties were sparsed across the country. So we had facilities that were within, a certain region. So the Nairobi, Nakuru region, and those that were in the coast, and those that were within the lakeside region. I'll talk about what happened now with the change package, because we're seeing the same things happening in different areas when people had never met. So we adopted the breakthrough series that is supported by the IHI. IHI is a big organization that is just supporting quality improvement work. And so we dubbed this program Quality and Efficiency. And using the breakthrough series, we're able to stage ourselves to look into what was going on in 2 years by beginning with pre-work, just understanding exactly what we wanted to do, having approvals within the Ministry of Health, setting up a team, a core team at the national program. This team was, of course, tasked with many other things, but they were also, mandated to support this particular work. And then engaging counties in just understanding what the sites would look like in terms of selection and potential quality improvement coaches. So they were able to select them, and then these coaches were earmarked and trained into being coaches. So given skills on how to become a coach, and introduced into certain skills. How do you even apply QI skills? And then baseline data was done that was in the 70 facilities, just to understand what was going on across the cascade in the different facilities. Then within the period, we had a series of learning sessions. Teams were converging at the different regions within the country. So those that are within Nairobi or at the central region, or western region and at the coastal region, and they would converge to share experiences on their problem analysis and also on some of the practices that they were doing. And in between, they had coaching meetings. We call them action periods. And within those times, they had support for hand-holding support for how to use the QI tools to apply and use them in their different projects. And then at the end of the day, they were able to come up with change ideas that were matched to see what's going on, and they were spread because there was evidence that they're likely to be going through, they're to be replicated if done at large scale. Next. So as mentioned, one key approach was the QI coaching. So Sarah, next, you can just drop them all. That in the QI coaching, so the national team was tasked to develop the QI, the coaching training materials, sorry, Sarah. Yeah, so they were able to come up with training packages and tools, and then they were able to continuously support capacity building of these county coaches, and incrementally introduce tools in the life cycle of the project, and support on-site coaching, the hand-holding process of applying PDSA to the facility teams. Next. So it was important to understand what systems they were focusing on. And as mentioned in the rapid scale-up, while it was imperative to test and start everyone, it was critical to ensure that we are supporting quality of care amidst all that rapid scale up, and also ensure that it was affordable in terms of cost, and there was enough time and resources that would be allocated for the needy clients and patients who are new, because then they would need like extra care. So the different facilities were able to take time to understand their system at that point. Now, the environment for DSD and QI, we were able to give an extra support in understanding how to additional training and guidelines, and understanding how to apply quality improvement concepts and skills in gap identification, redesigning of care pathways, and developing action plans to fill those gaps that they had identified. They were also put on an environment where they had peer learning between facilities. Next. And so in peer learning, the aim was really to build the confidence that among these participants that if they identify their potential gaps, then they were able to quickly look and share experiences that this facility did it, or I think I'm seeing the same thing around my facility. I can quickly test to see whether that was working. So we had series of those peer learning sessions. In terms of the PDSA application, these teams were supported to go through the PDSA model, you know, asking the fundamental question, what am I trying to accomplish? They would discover their aim or identify their aim. Then how will I know that a change is an improvement? They would apply some of the tools to the process analysis tools to understand their problem. And then how would you know that a change will result in an improvement? They would come up with certain change ideas and then come up with a work plan to test those kinds of changes using the PDSA. So step 1 to 4. Next. Yeah, so when answering the question, how will you know that a change is an improvement? Part of the work of the national team was to design a collaborative measures. You know, think through what are these things we want to measure to give us our aim, our outputs, our process measures and outcomes. So the teams were all exposed to these measures and supported to know how to identify what to measure, depending with what they were trying to track. Next. So interestingly, midway in the implementation, the national, the HIV program wanted to understand the degree to which DSD was being implemented across all 47 counties. And so they quickly asked the stakeholders across the board to come up with a criteria to see what is it going on across all the 47 counties. And it was should I say a multidisciplinary technical team. And next slide. So it was interesting that midway, the 7 counties that were already implementing this work actually had better scores when they were reporting back, because the first 5 positions were all taken by these 5 counties, and the last 2 counties were all the 7. And they articulated some of the steps that they were already undertaking while implementing DSD. They mentioned the first-in approach in DSD, the hand-holding process of coaching, the ability to use QI tools to plan and study what was going on, and the regular mentorship. So it more or less gave us a heads up that I think what we are doing is likely to result to something useful. Next. So some of the results that we saw from the work, this is just a few of them. We saw that like a facility in the coast was trying to support or understand linkage to care process. And here they were keen to look at to improve the proportions of newly identified patients who were linked within the 3 months of diagnosis. And they were able to apply the tools to understand what change idea would they want to, inject, and then annotate to see whether the change resulted to an improvement. Next. Yeah, this is a slide just showing what was going on in different settings, because it was like here we are seeing viral load uptake being reported in a few facilities at the coast, and another a set of facilities within the Western region, but they seem to be doing the same things and are getting similar results over time. Next. So one important thing while supporting quality improvement work is the ability to showcase or demonstrate that you can sustain the improvement. And so right from the word go, we staged the facilities to measure maturity in terms of planning and thinking through the projects and sustaining the functionality of those teams. And over the time, right from June 2018 through April 2019, we saw teams increasingly getting better scores, higher scores over time, just to reassure that when teams are functional, then they're able to sustain the momentum and the gains that they would have gotten over the period of time. Next. And so one other thing that in terms of outcome was that we're able to support facilities write home about their whole projects by walking through the PDSA cycle and documenting all the steps of the quality improvement that they undertook. So like this facility was working on viral suppression as a project. Next. Yeah, so I'll stop there, and before I do, just to usher in my colleague, Dr. Obare. So we were able to look at the evaluation. We did an evaluation just to see how the effect of quality improvement in DSD. And so Valerie, take it away. Thank you.
Thank you, Maureen, and I'll take the next session to just talk through what was the evaluation process and lessons learned from all this implementation and how it ended up informing policy and shifting how we are doing our implementation. So the purpose of this evaluation, it came at the end of the 2-year period of the intensive work that Maureen has described. Basically, we wanted to understand whether DC and QI had produced positive outcomes compared to facilities that were implementing DC without the additional mentorship, and at what cost was this? We wanted to also document the experience of DC and QI for a comprehensive range of outcomes, and we looked at patient satisfaction as well as experience in terms of cost. The other objective, or the reason why I wanted to do evaluation, was to provide a comprehensive picture of the quality of care and cost in facilities supported for DSD implementation with QI approach, compared to the facilities where DSD was happening organically without the additional support for QI mentorship. So in the arrangement of the study or the evaluation process, we had 3 work streams that we looked at. The first was issues around processes of care. Maureen described the change or the organizational issues that the facilities really planned around to improve their process of care and uptake of DC. And so in the evaluation, we wanted to see these adjustments or this process of care that facilities were implementing to improve service delivery. What was the final outcome? Then we also followed through issues of, sorry, Sarah, okay. We also followed issues of guidelines compliance, knowledge, given the intensity for mentorship that the work also entailed when the national team worked with the county teams. And we also wanted to understand the patient journey in the facility. What is their experience? What is the satisfaction in terms of service delivery? And ultimately, if differentiated care was, in terms of the experience of the uptake, did they understand what it did and how their final outcomes in terms of viral suppression compared to clients who are not on differentiated care? The second stream of work was around costing. We used the time-driven activity-based costing as a costing approach, and we wanted to see or measure the changes in terms of resource use and cost resulting from implementing DC and QI, understand what were the cost drivers for service delivery, understand the patient costs related in terms of coming to seek services, time efficiencies that were gained through the reorganization of the processes of care through DCQI implementation, as well as understanding the cost of providing ART per patient per year, and what were the patient costs also related for them coming to seek services from the various facilities. The third work package was related to client outcomes. When you've done these investments, you've maximized or you've optimized your service delivery pathways, do you still gain the desired health outcomes? Our index or our index for measure for health outcomes was viral suppression. We also did a quality of life EQ5D and most for HIV, but we also followed through a client satisfaction survey and provider satisfaction surveys to just see how then we were performing. So the main study objectives are enlisted. We wanted to demonstrate or evaluate program efficiencies in service delivery in both the intervention and control sites. We wanted to evaluate the patient and provider cost in intervention and control sites, and we wanted to determine the health outcomes to the patient and satisfaction. So next slide, Sarah. Next, so the result areas. I'll highlight the high level result areas for discussions. So one of the things we did when we were doing the CDA-BCM costing is the determination of the process maps and the time it takes for service delivery, and measure the resources, and at every step that we map in the process map of care, we map the resources that are utilized for service delivery. So in our typical process map, we would have the point of triage, who are the health workers involved in that step, what are the time that they take to offer the services at that step, what are the additional resources. And this was then accounted for, and it reflected in terms of the cost of service delivery. But at the same time, we also looked at our time for service delivery and in terms of client flow within the facility. So this slide was one of the key findings. There wasn't much difference between the intervention and control side, but in terms of clinical care or in terms of patient care, we noted that the issues around waiting time. If you look at how the process maps were done, the clients who were coming for their stable visits just for the ART pickup time are the ones who spent the least time in facilities. But it also reflected for us in terms of the contact time the clients have with the clinician for consultation time. How then do we improve our processes to really be able to ensure that the time the clients are in facilities is more taken in terms of contact with the healthcare worker. I'll discuss this as we get to the end and what it meant. Then as we rolled out test and start, it was really critical that the healthcare workers are able to pick up the test and start guidelines and be able to initiate timely ART among the clients. So if you see the time comparison between the control and intervention side, there was in terms of clients were initiated within 14 days, most of the clients in the intervention sites were able to be initiated within the 14 days. And compared to when we are starting the implementation of guidelines, you can see a big change that actually majority of clients were able to, majority of healthcare workers understood the guidelines, they were able to implement, and that continued mentorship to the facilities made us be able to gain the momentum for picking up on the test and start policy guidelines and continue with the fidelity for the guidelines in terms of our quality indices for service delivery. Next slide, please. So in terms of cost, this is a component of work package 2, cost comparison. There are two things that in this analysis or this data set it indicates. This is a health systems perspective. I know we had mentioned around the patient experience that was analyzed separately. But in terms of what it takes to deliver services, the process maps showed really similar patterns in terms of how client flow moves. But in certain facilities, we were able to do, despite the difference of the facilities, we were able to really pick up the main costs that are a component of the process maps. This basically are entailing the overhead costs, the human resource, the space that services are offered, the equipment that are utilized for service provision. And if you compare between the unstable, stable, and patient pickup, you see that really in terms of need or cost for what it takes to deliver services, most of the unstable clients, comparatively, if you compare, regardless of the intervention and the control side, they actually require more resources to take care of them. If we zero in then in terms of the intervention sites, in the intervention sites, you can see that for the stable clients, because the assumption was you would be able to spend time and shift resources for the clients who are most at need. You see that there's a little bit more time taken with these clients in terms of the time they take for counseling, in terms of the time they take for additional services that probably in other sites were missing. So for the stable clients in Kenya, the clinical visits are twice a year, but they have a in between for an ART pickup to just come and pick their drugs from the pharmacy. So if you take their unit costs combined for the clinical visit and their in between ART visit sites, it's still more affordable for them to be offered for services compared to those who are unstable. And this really pointed to the need for us to sustain interventions and follow-up that enable clients be suppressed and stable, because in the long term, in terms of the cost for the for service provision, then it becomes more cost effective for them. So Sarah, just before you go to the next slide, we know, so in terms of the unstable clients I think I've explained this. If you're going to really focus on giving quality of service, and in terms of the time interaction you have that with the facility, that contributed to the slide, because they were taking more focus in doing the counseling sessions and follow up for those clients. Next slide, please. So this is a summary in terms of then how does this composite unit cost then build up to inform the cost for ART per annum. We had the cost, what it takes to do a cost per visit. These were pretty standard across the facilities. What was really the main variant was the time and frequency with which then the client needed to come for a clinical visit. So in terms of this unstable clients, we know because they have to do multiple visits before they can go into the long clinical visits of every 6 months, then they utilize more resources in terms of their service delivery, and that made their cost of service delivery for the unstable clients much more compared to the stable clients. So for program quality and just in terms of ensuring positive outcomes for the clients, but also for health sector service delivery, it's really imperative to keep investments that support facilities to be able to pinpoint on issues that can then sustain the clients to be virally suppressed all through. So that is indicative, and we were able to demonstrate what it takes to do for a second line and what it takes to do for a first line. The lab costs become more because for an unstable client, then you need to do a little bit more tests compared to the rest. Next slide, please. So the additional cost to undertake quality improvement to support facilities, what Maureen was describing, what does it take for having a healthcare worker who understands how to identify bottlenecks in service delivery, identify problem areas that they want to work on as QI projects. It's a marginal cost. It's roughly $5 per client that you're going to invest in. So if you look at the beneficial outcomes of what it takes to follow through fidelity of guidelines, having mentorship, it really means that marginal investment of $5 might be really a proximal add in terms of the request for investment for countries or for sector. Follow through some of this guideline implementation and fidelity for supporting peripheral in our country setup. Some of our healthcare workers are really in the peripheral end, and that mentorship and support with them then is what turns around for us to see the result areas that we see. So we took the project cost based on the book of accounts. What we really put forward as the cost for implementation for this was mainly what went into the facility delivery of all these results that we have demonstrated. The startup cost, depending on how it is structured, and now that we have even integrated some of the implementation arrangements within the program, then the startup cost become a one-off cost. And we saw a lot of efficiency then in integrating QI within our routine programming areas. Next slide, please. So in terms of viral suppression, we were able to demonstrate between the intervention and the control site, the facilities that had more hand-holding, more process thinking around what does it take, what are the missed opportunities people see, how do we close on those gaps. You're able to see that their cohort of clients were able to sustain viral suppression. And even when they were on DC models and all that, the follow-up of those clients was more intentional compared to the control sites. And therefore, we were able to see that proportional differences between the intervention sites and the control sites in terms of viral suppression. Next slide, please. So one of the key lessons we learned during the evaluation process was really the interpretation of differentiated care. At the time when we were implementing in 2018, 2017, 2019 period, DC was relatively new in terms of implementation in the country, and how that was implemented or understood across different facilities, there was a bit of variation, and it would have been it was a good learning process for us to also see how then do we standardize some of the issues across facilities so that the understanding for what it means to be on a differentiated care is uniform across, and people can learn from each other as best practice to accelerate implementation. We needed to really explore opportunities to ensure more clients are stable. And since from the studies, we noticed it was actually cheaper to manage a stable client compared to a client who is unstable. So understanding what are the risks, what makes clients fall back and get not suppressed, what are the other factors? Is it co-infections? Is it missing appointments? What is it, this environment that we need to change and support the clients to achieve suppression? Then we also were able to say scaling up quality improvement approaches across the country. Findings suggest better client patient level indicators among the intervention sites. So key was patient satisfaction. We haven't explored that in detail because of time, but we were able to demonstrate for the clients who are in the intervention sites, they actually understood their cascade of care. They had more interactions with their service providers, and in terms of them anticipating what was going to happen for their next visit, that was demonstrated in the survey. So we also needed to address the patient waiting time. this was something for us as a take-home message. As much as we were doing differentiated care, because of how facilities were interpreting it, probably it wasn't yielding the results that we needed to do. But it was a learning lesson for us as a program, and also see how then we improve work efficiencies within the facilities and manage client time so that we reduce on that patient waiting time. Next slide, please. So so for next steps and what the country was able to inform policy and shift issues around scale up of the work that had been done, we were able to then revise the DSD operational manual, incorporating quality improvement. This has been a critical policy document in terms of the DSD implementation in the country. We've expanded the scope and the cohort for client cohorts. Initially, when we were doing DSD, it was just among the adult clients. Right now, the policy document allows for other subpopulations that then would benefit from a different models for DSD that also allows for them to get better service delivery and client outcomes. We also need to expand the discussions for DSD or differentiated service delivery beyond treatment and consider what it means for HIV prevention services as well. We've seen opportunities around scaling up of PrEP outside of facility for prevention services, and we hope that the lessons we've learned through QI and DSD can actually inform some of this, because it's going to be a new territory for implementation, given that prevention is the context for prevention might be different from the context for treatment, but it's still an opportunity for us to follow through and see the outcomes for this implementation phase. Then in terms of the guidelines, we've standardized treatment guidelines, and DSD then has become an important core for service delivery and quality improvement. We have quality improvement topics that are disseminated as part of guidelines, so that you don't have to separate the trainings for different scope of clients. They understand quality improvement is part of service delivery, and it's something that they need to understand as they implement work at facility level. Over and above that, there's a virtual platform that the program then developed to utilize it as a follow-up for county coaching and mentorship by the national officers. This has created a forum for the national program to have a more in-touch discussion with facilities to just scale up quality improvement and follow through for projects and programmatic gap areas that can support to change the client outcomes. We've seen the expansion of QI in routine HIV service delivery. This project initially was heavily around treatment care, but we've seen as you expand the conversation, issues around pediatrics and adolescent care and EMTCT elimination agenda. What are the missed opportunities, and how is quality improvement really a critical component for programming in these areas, has been something that has been expanded so that the teams can support other program areas beyond care and treatment. Then we have been able to upgrade the EMR modules to be able to improve the documentation of client uptake for DSD, and also monitor their outcomes at facility level that have EMR. Next slide, please. So thanks, and over to the team.